If ringing suddenly follows you after 60, the sound may feel alarming, but tinnitus itself can have several causes. Some people hear a high-pitched tone, while others notice buzzing, hissing, humming, clicking, or a pulsing sound. The pattern matters because ringing in both ears can mean something different from sound heard on only one side. A sound that matches your heartbeat also deserves a different evaluation from a steady tone that never seems to change. Most tinnitus is not a medical emergency, but certain combinations of symptoms should be assessed without delay. The useful goal is not to guess the cause from the sound alone, but to identify the pattern and the next right step. You are watching Dr. Edward, where we explain practical health information for adults over 60 in plain language. Today we will cover 7 tinnitus causes, warning signs, and options that may make the sound easier to live with. This is general health education because new ear symptoms, medicines, and hearing changes need individual assessment. Tinnitus means hearing a sound when there is no matching external sound source, and it can affect one ear or both ears. It may come and go, or stay constant, and people describe it as ringing, buzzing, hissing, roaring, clicking, or humming. The sound can feel loud even when hearing tests show only modest changes, because perception involves the ear and brain. Cause number 1 is age-related hearing loss, one of the most common hearing changes affecting adults in later life. As inner ear sensory cells and hearing pathways change with age, the brain receives less normal sound information. Tinnitus can appear alongside that hearing loss, even when you have not yet noticed how much your hearing has changed. That is why a hearing test can be useful even when the ringing seems like the only symptom you are experiencing. Cause number 2 is past or current loud noise exposure, including machinery, firearms, concerts, or power equipment. A single intense sound can injure hearing, while repeated exposure over years can also damage delicate inner ear cells. The ringing may start soon after loud noise or become noticeable much later, especially as hearing declines with age. Protecting your ears from future harmful noise still matters, because additional damage can worsen hearing over time. Cause number 3 is medication, because some medicines can trigger tinnitus or make an existing sound more noticeable. Examples can include certain pain medicines, antibiotics, cancer drugs, and other medicines with effects on hearing. The risk depends on the specific drug, dose, duration, kidney function, and other factors unique to each individual. Never stop a prescribed medicine on your own because of ringing. Instead, review the timing with your clinician. Cause number 4 is earwax, infection, or fluid, because changes in the ear canal or middle ear can alter sound input. A blocked ear may feel full or muffled, and some people notice tinnitus until the underlying ear problem is treated. Do not push cotton swabs deep into the ear canal, because they can pack wax farther inward or injure delicate tissues. An examination can show whether wax, infection, fluid, or another local ear problem is contributing to the symptom. Cause number 5 is jaw or TMJ trouble, especially when clenching, grinding, or jaw movement changes the ringing. The jaw joint sits close to structures around the ear, so muscle tension and joint problems can influence tinnitus. If the sound changes when you clench your teeth or move your jaw, mention that detail during your medical evaluation. That clue does not prove a jaw disorder, but it can help guide the clinician toward a more complete assessment. Cause number 6 is an inner ear disorder such as Meniere's disease, which can involve tinnitus and hearing changes. Meniere's disease can also cause episodes of vertigo and a feeling of pressure or fullness in the affected ear. Tinnitus alone does not diagnose Meniere's disease, so the pattern of hearing, balance, and pressure symptoms matters. If spinning attacks or fluctuating hearing accompany the ringing, an ear specialist may need to evaluate the pattern. Cause number 7 involves blood flow, especially when the sound pulses with your heartbeat instead of staying steady. Pulsatile tinnitus can have vascular causes, so persistent heartbeat synchronous noise deserves medical assessment. High blood pressure can be associated with pulsatile tinnitus, but the sound itself does not diagnose hypertension. Now we need to separate annoying tinnitus from warning patterns that can change how quickly you should seek care. Tinnitus with sudden hearing loss is one of the most important combinations because early assessment can matter greatly. If hearing drops suddenly over 3 days or less, especially within the past month, urgent evaluation is recommended. Persistent ringing in only one ear also deserves assessment, particularly if hearing is different between the two sides. Persistent pulsatile tinnitus should be evaluated because blood vessel or neurological causes may need to be excluded. New facial weakness, severe neurological symptoms, or intense new vertigo with hearing changes require urgent attention. The point is not to make every ringing sound frightening, but to recognize the patterns that deserve faster evaluation. The encouraging news is that even when tinnitus remains, several strategies can reduce how disruptive it feels each day. Before we build that plan, subscribe and tap the bell for clear health information designed for adults over 60. If ringing has been bothering you, stay with me because the next steps can help organize what to check and what to try. After the full plan, type 1 in the comments if you want more practical videos about hearing and aging after 60. Step 1 is to describe the sound clearly. Is it ringing, buzzing, hissing, clicking, roaring, humming, or a pulse? Then note whether it is in the right ear, left ear, both ears, or somewhere in the head, and whether it comes and goes. Write down when it started, what was happening around that time, and whether any new medicine or loud noise came first. Step 2 is to notice your hearing, especially if speech sounds muffled or conversations become harder in noisy places. A formal hearing test can reveal age-related or asymmetric hearing loss that may not be obvious in everyday situations. If hearing loss is present, hearing aids may help by improving access to outside sound and reducing the contrast. Step 3 is to review every medicine and supplement with a clinician or pharmacist, including non-prescription drugs. Bring the actual bottles or a current medication list so dose changes and timing can be compared with tinnitus onset. Do not assume a drug is responsible because tinnitus appears on a side effect list. The clinical context still matters. Step 4 is to have the ear examined if you notice fullness, pain, drainage, muffled hearing, or a blocked feeling. Treating impacted wax, infection, or another correctable ear problem may reduce tinnitus when that is the trigger. Do not pour unverified remedies into the ear because some products can irritate the canal or harm an injured eardrum. Step 5 is to mention jaw pain, tooth grinding, clenching, or a ringing sound that changes when the jaw moves. A dental or TMJ evaluation may help when the symptom pattern points toward jaw muscles or the temporomandibular joint. Step 6 is to protect your hearing from future excessive noise without trying to live in complete silence all day. Use appropriate hearing protection around loud equipment, concerts, firearms, or other environments with harmful sound. Constant overprotection in ordinary safe environments can make everyday sounds feel unusually prominent over time. Step 7 is to use gentle background sound if silence makes the tinnitus dominate your attention, especially at night. A fan, quiet music, nature sounds, or a sound generator can reduce the contrast between tinnitus and a silent room. Sound therapy does not erase the tinnitus signal, but it can make the sound less intrusive for some people over time. For bothersome tinnitus, cognitive behavioral therapy can help reduce distress and improve quality of life and coping. CBT does not claim the ear sound disappears. Instead, it changes the emotional and behavioral response to the sound. Current VA and DoD guidance also supports structured tinnitus education as part of a patient-centered management plan. If hearing loss accompanies tinnitus, an audiologist can discuss hearing aids and other hearing rehabilitation options. Some people benefit from combining sound strategies with CBT rather than relying on one method as a complete solution. Be cautious with supplements sold as tinnitus cures because current guidelines do not support common nutraceuticals. Ginkgo, vitamins, herbs, and other supplements should not be assumed to stop tinnitus simply because marketing says so. A deficiency should be treated when it is actually diagnosed, but tinnitus alone does not prove you lack a vitamin. Sleep also matters because tinnitus often feels louder when the room is quiet and the brain is tired or stressed. Use a consistent sleep routine and gentle background sound if it helps, while treating insomnia separately when needed. Stress does not mean tinnitus is imaginary, but anxiety and hypervigilance can make the sound harder to ignore. Relaxation, counseling, and CBT can reduce that distress even when the underlying auditory signal remains present. If the ringing suddenly changes, becomes one-sided, starts pulsing, or arrives with hearing loss, update your clinician. Your evaluation may include an ear exam, hearing test, medication review, and referral based on the pattern you report. The most useful detail is often not how loud the sound feels, but what accompanies it and how the pattern has changed. Age-related hearing loss and noise exposure are common explanations, yet tinnitus should never be reduced to age alone. Medication effects, wax, jaw problems, inner ear disease, and blood flow causes can require very different next steps. That is why copying a supplement recommendation from someone else's tinnitus story can send you in the wrong direction. A good plan starts with identifying reversible contributors, checking hearing, and reducing distress around the sound. If no dangerous cause is found, management can still improve sleep, concentration, communication, and quality of life. The goal may be less awareness and distress rather than complete silence, and that can still be meaningful progress. One bonus clue is whether movement changes the sound, because jaw or neck motion can sometimes modify tinnitus. Another clue is rhythm. A pulse matching your heartbeat should be described clearly rather than called ordinary ringing. Bring those details to the appointment, including which ear, timing, hearing changes, noise exposure, and medicines. A short symptom record can make evaluation more useful and help you notice whether the pattern is truly changing. The key lesson is that tinnitus after 60 has many possible causes, and the sound alone cannot reveal which one you have. Seek urgent care for sudden hearing loss or serious neurological symptoms, and evaluation for persistent red flags. Subscribe for practical health education after 60 and bring persistent tinnitus to a healthcare professional.